Welcome to the Illuminated Darkroom podcast. Today I am in true full nerdy heaven. I have with me two really brilliant and amazing women, and I'm so honored to have Dr. Christina Kanagaratnam and Dr. Omolayo Famuyide on the second season. This is my inaugural episode of the second season of my podcast. So thank you so much for being here. I'm just going to go ahead and introduce you guys. Dr. Christina Kanagaratnam is a skilled family physician with vast experience in both rural and urban family medicine for over 2 decades. She started her training in the UK at the Imperial College School of Medicine and completed her training both in the UK and Canada. She obtained several specialized professional training and postgraduate qualifications. And I'm going to list a few of them. She's a member of the Royal College of Physicians, member of the Royal College of General Practitioner in UK, diploma in the Royal College of Obstetricians and Gynecologists in UK, diploma in family planning. She's a certified menopause practitioner. She's got a certification in the College of Family Physicians, and she's a fellow of the College of Family Physicians of Canada. Dr. Kanagaratnam is a Menopause Society certified practitioner. She has extensive training and experience in women's health services, and she has a true passion and dedication for the care of women in midlife, thank God. Okay, Dr. Kanagaratnam is the founder and owner of Spring Creek Medical Center right here in Calgary, where she's dedicated to delivering excellence in every aspect of patient care, including evidence-based menopause care. She's a proud mom to a teenage son, and in her spare time, she loves spending time with her family and friends. Welcome, Dr. Kanagaratnam. And Dr. Omolayo Famuyide is the founder and medical director of the Layo Centre, a comprehensive clinic providing women's health services in Winnipeg, Manitoba. She's a former practicing pharmacist and family physician, which uniquely positions her to serve patients in her well-established women's health practice. Her passion for women's health led to the completion of a 12-month fellowship at the University of Toronto, which is a world-leading institution in women's health. She is also a certified menopause practitioner through the Menopause Society, formerly the North American Menopause Society. Her proficiency in the areas of reproductive health, advanced contraception, and menopause is well regarded. Dr. Famuyide is a known expert in the areas of contraception and menopause, having been invited to speak on these topics to various medical trainees, practitioners, and other allied health professionals. She's frequently called upon as a health expert to speak in the media with appearances on Global News, CTV News, City News, the Winnipeg Free Press, and most recently, Chatelaine magazine. Most recently, she was honored to be selected as a recipient of Canada's Top 100 Black Women to Watch of 2024. Beyond her role as a clinician, Dr. Famuyide is a mom to a lovely son, self-proclaimed foodie who enjoys spending any extra time she has dedicated to fitness and travel. She's also an educator and an advocate for women's health. Welcome. Before I get started, I just want to put out a quick reminder, even though we're all physicians here, the information in this episode is for general education and conversation. It's not meant as personalized medical advice, so please consult your own healthcare provider for anything related to your health. Welcome.
Thank you. Thank you for having us.
My pleasure. Now, we're going to cover a lot of topics here, okay? Menopause, perimenopause, everywhere you look, it's in the media, social media, mainstream media. But here's the thing is that despite all the information out there, there's still so much confusion. Whether it's in Canada, in the States, in the UK, there's so many myths. There's not enough specialists who really understand the space. And that's why I'm so excited to have you both here to speak on it, especially that you're both Canadians as well. So let's start with this question. We've gone to med school. This is not something that's taught as much. What drew you both to wanting to specialize in this particular field? Dr. Kanagaratnam, I'll have you go first.
Right. So I think I was kind of fortunate enough to do my training before the WHI study came out. So I did get a fair amount of training in menopause. Later on, during my practice, I've started seeing patients coming to see me complaining of symptoms. All during the menopause transition, they were really struggling And looking back, there was a period of time that we stopped addressing menopause symptoms for patients. So I felt that we're really not helping these women. So I stepped back, went and did the certification, extra training in menopause, and became more confident in addressing and it being able to provide care for these women.
That's awesome. So you trained after the Women's Health Initiative study, and then you saw the need, and then you went. That's awesome. Thank God. I'm so glad you did that. What about you, Dr. Famuyide? How did you get into this?
Yeah, I would say for myself, so I'm a family physician by training. And so when I ended up doing extra training in women's health, I always knew that I wanted to center my practice moving forward around women. I'll be honest, I think I lean more initially towards general gynecology, which is still a big part of my practice. But I kind of landed in the menopause space during my fellowship, ended up working with very well-known, one of our leading menopause experts in the country, Dr. Wendy Welfman. And so kind of landed in one of her clinics and ended up really falling in love with this topic of menopause that I truly knew nothing about. And I think for me, that journey has sort of led to this identified need, not only to address menopause, but also certainly in the perimenopausal space. And it's something I think as a practitioner is actually super rewarding when you do get a chance to meet with women and, be able to help them in some of these little areas of their life that end up being actually significant parts of their midlife transition.
Okay, that's awesome. Did you ever imagine that there would be such a need as we have right now?
Not at all.
Not really, no.
Not at all.
I mean, it's crazy. There's wait lists, as you know, like 18 to 24 months, right? And there are a lot of women in Canada that do not have family physicians. So I'm so glad that you guys did this. So let's start with definitions. Dr. Kanagaratnam, can you tell us what menopause is and what is perimenopause? So, tell me all what you want to say about this topic.
So menopause is when women don't have a period for a minimum of 12 months. And then perimenopause is a stage that leads you up to menopause where your periods can be erratic. So there's usually a fluctuations in hormone levels during that period with gradual cessation of reduction in the level of estrogen. So perimenopause, women do struggle quite a bit with their symptoms leading into menopause.
So fair to say menopause is one day, 12 months after you've had your last period.
Yes.
And perimenopause is
leading up
to it. Is it, especially in the perimenopause period, is it mostly about your periods, menstrual cycle, or is it more about the symptoms?
It's a combination. So, like I said, the perimenopausal stage, women can be very symptomatic. So, as well as the periods can become very erratic, from shorter cycle to longer cycle to cycles can become very painful and heavy. So it's a combination of both symptoms and the periods.
What about women that don't have periods?
Again, even if they don't have a period, especially if they have a Mirena IUD or a hormonal type of IUD, the way we diagnose that is possibly by listening to their story, getting this history, what kind of symptoms they're going through. And on those women, we can also look at doing some blood tests. So we don't diagnose menopause with blood tests. However, there are certain conditions where we will do blood tests, but that will be when women don't have a period due to other reasons.
What would you say is the average age for menopause? And I want to talk a little bit about this blood test because there are different schools of thought. You have people that will do blood tests, and I have had my blood tests done, to see if I'm in menopause. But there's also that train of thought, no, you really don't want to do blood tests. It's all about symptoms. So what would you say is the average age of menopause, and when would you consider doing a blood test?
So average age in North America is around 51.
Okay.
When will I be arranging blood tests? Only for specific reasons. So if I see a woman who is below the age of 45 or having early menopause, that will be an indication to do blood tests. Or if a woman had a surgical menopause where they had their ovaries removed and we are not quite sure where they're at, then that'll be an indication. Or if they had a Mirena IUD, and they have no periods. So it's just to get an idea. So it'll be more specific according to their conditions and where they're at.
Awesome. I love that explanation. Thank you very much. Now, I'd love to break down how menopause impacts different aspects of women's health, so it's because it's more than just hot flashes, really, right? So Dr. Famuyide, can you start us off and talk about menopause, how it's associated with bone health, things like osteoporosis, heart health, and maybe you can talk about metabolism and sleep hygiene and all that.
Yeah. So I think one of the things that's really important when it comes to menopause, I think, one of the driving factors, I think, that's really shaped how we manage patients these days is the significant impact we know it can have on their quality of life. So aside from addressing women's symptoms around sleep and mood and vasomotor symptoms around flushes and night sweats, we know that the menopausal transition also comes with a lot of physiological changes that involve, physical characteristics, for example. So women's skin, their hair, their nails. We're talking vulvovaginal symptoms. So we also see, long-standing changes that can impact a woman's bone health. The menopausal transition, generally, we do tend to see this decline in ovarian function, which often a big driver of that are, hormones, including estrogen. And so most women are often going to be more susceptible to lower bone density. So again, it doesn't mean that every woman who undergoes the menopausal transition is destined for osteoporosis per se, but we know that it's imperative for women around this midlife transition to be focused on nutritional supplementation around calcium intake, vitamin D, resistance training. All these are non-pharmacological and non-drug measures that we can use to certainly strengthen bone health. The other thing we know that's also happening is from a cardiovascular perspective. We know that the endothelial cells often are more susceptible to plaque deposition. We tend to see endothelial changes, and a lot of this has actually been looked at in various different studies, seeing that this often can lead to an increased incidence of things like cardiovascular disease and coronary artery disease in women. The other sort of things that we tend to see from a metabolic perspective include insulin resistance. We know that especially even in the perimenopausal changes, it's not uncommon that when we measure blood work in women and we're trying to do risk stratification, we start to see those hemoglobin A1C markers creeping up. A big part of that can certainly be the deposition of central adiposity. So a lot of women will report, I have not only weight gain, but it tends to be in that midsection. And so those sort of things can not only increase one's risk for things like type 2 diabetes, which can subsequently, especially in the combination of insulin resistance, can mean lipoprotein factors are changing, so high cholesterol, and subsequently a combination of these things do tend to increase women's risk for things like coronary artery disease and certainly also things like strokes.
You mentioned all these things. It's the plaque deposition, weight around the middle. Is this because of a drop in estrogen only, progesterone, both? What is really the culprit? Why is this happening?
Yeah, it's a great question. And I think when we look at the midlife transition, we know that there are several hormonal factors involved, but we know that one of the primary drivers often actually is estrogen. Progesterone certainly has a role, but when it comes to some of these cardiovascular benefit, we can often see, and the impact on bone health, that is often an estrogen-mediated and driven aspect. While we speak about these changes in the midlife transition, I do think it's also really important that we not necessarily conclude that, if we put every woman on estrogen, that I'm going to for sure confidently prevent that, risk of you having a heart attack or you having a stroke. But I think what is really important for us to acknowledge is that the midlife transition certainly increases women's risk. And many of us are aware of the statistic that the number one killer of women is heart disease. And we have no doubt that menopause is a big contributor for that. And certainly we also have to think about some of the ethnic and racial contributing factors, which are non-modifiable risk factors that we know in certain ethnic groups also further increases their risk.
Dr. Kanagaratnam, could you talk about what happens with our sexual health, brain changes, and mental well-being during this stage?
Right. So mental health and the menopause transition are quite closely linked. So like you mentioned before, menopause is not just about hot flashes. Women go through tremendous time with their psychological and social changes that goes on in their life. So they can often present with mood swings, depressive symptoms, anxiety to panic attacks, which sometimes they will say we've never ever struggled with any kind of anxiety symptoms in the past, severe irritability. Some women come to say they have brain fog, they really can't get going, they're really struggling at work. So those kind of psychological symptoms we know are also part of the perimenopause to menopause transition period, which as practitioners we should be aware of it and should be able to support and help them. In most cases, we also look for risk factors. So if patients have previously had history of depression, ever in the past taken antidepressants, or if they struggle with postpartum depression, severe PMS, those are all kind of risk factors that they could develop postmenopausal or perimenopausal depressive or psychological symptoms. So there's multiple ways we can support and help them through that process.
So is it fair to say that, for example, if someone's had depression in the past or maybe postpartum depression, that the likelihood of them developing symptoms similar to this in perimenopause and menopause is higher?
It is, yes. Yeah.
And, I hear, I was going to say, I hear women that reach out. I was literally about to say, I'm not one of them, but my husband might disagree. I feel like I'm not a rager. But anyway, there's women, I have a friend that says, I just rage, like, I'm just so mad at my husband. Is that one of the reasons why?
Yes. Yeah.
Okay.
Yeah.
And then how do you know? I mean, we can't blame everything on menopause, perimenopause. How do you know that this is related to that versus there are other contributing factors?
Right. So that again goes down to taking a detailed clinical history. So talking to the patient, really doing some screening questions regarding their mental health, also finding out where they are in their life, whether they have young teenage kids they're taking care of, or is they got a big promotion at their work. They got so much responsibility on their hands, or do they have elderly parents they're taking care of? So there's multiple psychosocial things that goes on, as well as the psychological symptoms of menopause. So it's really important to go through a detailed history to be able to help them navigate.
And if I can add to that, I think one of the things women will often actually say themselves is, I don't feel like myself, right? And it's, I think we see various different iterations of what women will describe that. But I often think that really links to the mood things, like as Christina has alluded to, right? If a woman comes in and she doesn't have that history, she doesn't have major stressors or nothing has really changed. And you'll often hear women echo that, like, yes, I'm busy, I have X, Y, and Z, but something is just different, right?
Yeah.
And, that's when we kind of need to start leaning, this could be an early presentation or part of your midlife transition, because some folks are not our fleshers, right? They're not going to be the ones up multiple times at night. They present with a predominant mood component.
I also forgot to mention sleep.
Yes.
So that's the other thing that they come to tell us about, not just because of night sweats. They just can't sleep, and they've been fine all these years. So again, we need to be aware of those symptoms as well.
So there's just a change, something, Okay, interesting. Dr. Famuyide, can you comment on the genital urinary symptoms as well as the sexual health symptoms as it relates to menopause, perimenopause?
Yeah, absolutely. So I think when it comes to menopausal symptoms, there are well over 30 validated symptoms. So what I mean by that is there are several symptoms that have actually now been validated to be associated with the menopausal and midlife transition. I do feel very commonly that some of the sexual health and sexual side effects and the genital urinary syndrome, and mainly those involve the vulva and the urinary system, sometimes kind of get forgotten about. So it's not uncommon that many women will present with sexual health concerns, and many of that could present as things like reduction libido, changes in desire, changes in achieving an orgasm, and the list goes on. What can be challenging sometimes around the sexual health and sexual function for many of our patients is that a lot of that is also multifactorial, right? So it really can be impacted and often is based on a woman's mood. Is she sleeping? Are there substances involved, etc.? there's a whole different category of symptoms where we abbreviate as GSM, which stands for genital urinary syndrome of menopause.
Right.
And that is actually really meant to highlight the changes that occur in the vulva, the vagina, and the urethra, so around the bladder system.
Okay.
And so many of those symptoms often present with, and women will present with symptoms of vaginal dryness, pain with penetration, irritation, burning symptoms. It's not uncommon that women will tie some of these symptoms often with any form of penetration. And I think it's important for patients to be aware, like many women will walk around actually saying, I can't wear certain clothes. I just feel really uncomfortable down below. And then many women from a urinary and bladder perspective will present with frequency, urgency. We'll see women waking up multiple times in the middle of the night. One of the most common ways we can actually prevent things like UTI, so bladder infections, which again is a constellation of GSM, and a very common presentation is, instead of women presenting to the doctor all the time with these bladder infections and getting antibiotics, we often will encourage using things like vaginal estrogen. And so when it comes to many of the GSM symptoms, we don't necessarily need to prescribe our systemic therapy. So those would be our oral medications, things you take through the skin. We can actually start vaginal estrogen at really any age to address some of those symptoms.
I want to come back to especially this topic around the genital urinary symptoms, vaginal estrogen, and sexual health, especially from a cultural, racialized lens, because this is so important. You know, I think I'm sitting here with these three racialized women sitting here, you know, and I feel like this is something that a lot of women are not as comfortable talking about. And it's important in our daily lives. It's good to have great sex, and people are not talking about this. We need to talk about this.
Yeah,
you know?
that's true.
Moving on, I want to bring in a study here that I think really changed the conversation about menopause, and that would be the SWAN study. So for our listeners, SWAN stands for Study of Women's Health Across the Nation. Dr. Famuyide, can you talk about this study, why it matters, and were there any limitations?
Yeah.
You know, maybe they weren't.
Yeah. So this SWAN study, and I think just to give our listeners some context, so this study was a multi-city study that actually took place in the United States across 7 different centers, medical centers. So they were responsible for recruiting women, many kind of looking at women in the postmenopausal transition. And it was actually a study that began in 1994. So we're talking well over 30 years later. We're still leaning on the study and the information that we gathered from it. And I think why it is really important when we're looking at some of the ethnic and racial experiences of women around menopause. To date, the SWAN study is still the largest study we had. It looked at, and they actually ended up recruiting about 3,000 women, several different ethnicities. But I think one of the, as you mentioned, one of the limitations were there were certain ethnic groups that were not included in the study. So the study looked at and actually assessed the experience of 3,000 women coming predominantly from white populations, so Caucasian women, African-American women, so Black women. They had Hispanic women enrolled, and they had Japanese and Chinese women enrolled. Certain groups were missing, and some of our, if we think about, the experiences of our, South Asian women, they were not enrolled in the study. We did not have Indigenous women enrolled in these studies. But and certainly while that's a huge limitation, one of the things that we did learn from this study was that the experiences of menopause is certainly not the same across ethnicities. And so if we were to kind of break down some of the key highlights of that study, I think we learned that certain ethnic groups, specifically Black populations and Hispanic populations, tend to actually experience menopausal symptoms for much longer. So specifically Black women were noted to experience menopause on average menopausal symptoms, I should say, for an average of 10 years, compared to their white counterparts, about 6.4 years. We also noted that Hispanic women and Black women were also more likely to present with earlier presentations of menopause and also present with more severe symptoms. So interestingly enough, we noted that these women were more likely to present with higher severity of vasomotor symptoms, so the hot flushes, the night sweats, compared to their white counterparts. We noted that, our Asian counterparts in these studies, so specifically Japanese and Chinese women, were actually not noted to present with their severity of vasomotor symptoms were not as high. some of the things that were really hard to often assess, and part of this actually leans against things like GSM. So in certain cultural groups, for example, Black populations, some of the Asian populations they looked at, GSM symptoms were rarely reported. They were more likely to be reported in our white populations. And I suspect a big part of that actually likely has to do with just cultural confidence
I was just going to
and
say,
comfort, right? Because I think, especially, as a Black woman myself, we don't talk about sex. We don't talk about, what does your vagina feel like? What should it feel like? Should intercourse be painful? Should it not be painful? So I think while some of those things in the study may not have been, we don't want to interpret those things as Black women may not experience the same level of symptoms, because there likely was a bit of a cultural barrier there. When we look at things like mood, I think one thing that came across the board is that, it was actually really hard to assess some of that, because we know that in many of our big studies, when we look at Women's Health Initiative, things like the KEEPS trial, a lot of our people are persons of color, often excluded from these studies. So we miss an opportunity to truly understand depression symptoms, mood, and cognitive symptoms. One of the things I think is really important, especially when we're looking at Black populations, is that, and I think this really came through in the study, the SWAN study specifically, was that there is such a significant element of systemic racism, discrimination, access to care that often impacts Hispanic groups, Black populations compared to some of the other ethnic populations in this particular study. And while those are key aspects to addressing the menopausal and midlife symptoms, we also know that when women are dealing with some of these day-to-day stressors, day-to-day pressures, access to, we're talking about, our basic needs, right? Housing, food, shelter, education. When these things are very hard for women to access, it's going to make it really challenging for them to ultimately be able to obtain healthcare access to have some of those symptoms addressed.
Yeah. So there's so much there. I wanted to touch on this and talk about it so that people understand that, there are cultural differences. And Canada is a racially diverse population, even more so now than it ever was, right? And so when women are going to see their providers, for the providers to recognize that. And I guess a question I have too is, knowing this, is there a way for, let's say, a Southeast Asian woman to say, I wonder what it's like in my culture? Is there a place where they can go to find that information? Or do you think it's more from, let's talk to our community?
Right. So again, I think that's another issue with the South Asian community. Unfortunately, there's this huge stigma attached to menopause and sexual health and mental health. So women don't usually come up to the doctors and say, I'm going through menopause. Can I go on hormone therapy? Can you help me? Usually they will present a bit late, and their symptoms often tend to be nonspecific. So usually like brain fog, fatigue, body pain. So it's the practitioners have to be more aware and be able to help them through that. So
that's why representation matters. You talked about Indigenous women. I think, when you go to somebody that's of the same culture, looks like you, there's that comfort there that is unspoken.
Absolutely.
And perhaps they're going to be more comfortable, talking to the same person about it. This to say that it's important, while we're looking for that help, it's super important for us to speak up, advocate for yourself, because that's the only way that we're going to be able to get that help, right?
The whole idea of menopause and midlife transition often gets pathologized, right? We see it as this state, and I think the culture around perimenopause and menopause and the conversations around it about, let's embrace this transition, let's make sure women aren't suffering. But it's important to also acknowledge in a lot of cultures, including Indigenous cultures, like studies have actually looked at this, that it's often not looked as this medical problem as we tend to look at it, right? A lot of Indigenous cultures look at this as truly what it is, as this natural transition that should be celebrated. And it does not necessarily it may not necessarily be interpreted something that needs to be medically treated because it is not seen as a disease state, if that makes sense.
No, it absolutely does.
Yeah.
You know, I think I remember when I first started practice, I mean, young, you know, working with women in my practice, and I was told, oh, you wait till you get to this point where you're going to feel so hot. It was almost punitive, you know, and I'm like, well, what is that? That's never going to happen to me because I'm cold all the time. Well, hello. You know, here we are, right?
Exactly.
Different story. Yeah, but yeah, there's certainly a way of looking at it that seems almost like it's pathologic, like you said.
Yeah.
Absolutely. Yeah, I totally agree with that. Christina, what has been your experience in your practice comparing menopause and its symptoms in both racialized and non-racialized women? I'm really curious to hear about that and what you see.
Yeah, so like I mentioned earlier, it's again, my population, I do work with fair amount of South Asian population as well. So again, when patients present, it's not like Omolayo mentioned, it's not pathologized. It's just a part of my life that I'm going through.
I love that.
So yeah, so if I kind of ask them specific questions, are you getting hot flashes? Are you having problems sleeping? Is there body aches and pains? Are they something new that you never had before? So if I'm very specific, asking them those specific questions, then they will often come up with answers to be able to kind of come up with a solution for them. But they would never come up to talk about menopause. Very rarely happens.
So I'm so curious. Do you have, you know, in my practice, sometimes I have like partners, husbands come in with their, you know, spouses and they want to hear what's happening with their breast health. Is there any chance that you have any men that come in with their spouses to want to hear about their menopausal, perimenopausal health at all?
Not so much in my practice.
Not so much?
Yeah.
Okay, that's interesting. What about you?
I definitely do.
Okay.
I would certainly say most women still come in to the consult on their own.
Okay.
Even if a partner or spouse, especially like, you know, if we're referring to like heterosexual relationships, you know, the male partner will wait in the waiting room, but I definitely will have them come into the room with us. And I always welcome it. I think, you know, if we think about, you know, this midlife transition, it can be really quite isolating for a lot of women, right? Not everybody has that support system, or not everyone feels comfortable dialing a friend. Hey, like, you know, this is what happened to me last night. Do you feel this way? Right. So I think having partners involved and, you know, informed in this process, you know, when we were speaking earlier about, you know, the whole idea of the midlife transition impacting sexual health. And I think, you know, when these partners in the room, it is such a good opportunity for us to speak to this is truly a multifactorial, and it takes everybody, you know, everyone's participation. So I always welcome it. I love it. I think that, you know, if you're a male partner listening to this episode, like, save this one and listen to it on repeat. I think you should all be
absolutely
a bit more informed.
Yes, I completely agree. And again, maybe culturally some women are shy about this, but I think it's important to let your partner know, you know, like, especially as you mentioned, the sexual health is important. Like if you have vaginal dryness, more lube, you know, it's okay, check. But you have to have that conversation, you know, because they're probably wondering, is it me?
Totally.
You know, when in fact it really isn't, you know. So again, power in speaking up and saying, hey, hon, here's the issue. And
right.
A good way to do it is to come to the appointment with your partner.
I fully agree. And I think, as you said too, like just that last point, so many women tend to lean on internalizing it's a me issue, when this is, again, a natural transition. If you live long enough, most women will go through, if you don't have surgical or medical causes that contribute to this transition. So the more your partners know about what is happening with you and your health, it should be a win for your relationship and your, you know, whole network.
Yeah, I completely agree. Now, we were talking about cultural differences, and I was wondering, are you seeing the same thing in your office regarding symptoms of menopause in racialized versus non-racialized women? What are you seeing?
Yeah, you know, it's interesting because so my practice is based in Winnipeg, and I have to say, even as a woman of color who delivers midlife care, I don't see too many persons of color, specifically Black women, in my practice. And I think it's something that I still continue to wonder, Why? Especially when we know, when we refer to studies like the SWAN study, Black women are more likely to present earlier. They're more symptomatic for longer, right? I don't tend to see the same level of presentation, but I will say that when I do see women come in, it is consistent with the data, right? We do tend to see persons of color. So whether you, are of, Black ethnicity, whether you're of, South Asian descent, I have Indigenous, persons in my practice. I find that most persons of color will tend to present in a very different fashion. And I think one of the things that I know I'm really quite conscious about in my practice is that, and we see this a lot with a lot of colleagues, that a lot of the type of care we provide is still really tailored to white women, right? When we look at studies that are out there, a lot of, minority groups and racialized populations are often excluded, or investigators aren't conscious about including certain ethnic groups. And so I think even when we think about recommendations we make and how we deliver the care we do, it's still really kind of interpreted as this one size fits all. And I think it's really important for us to not approach every woman who comes into our office, especially women of various different backgrounds, that the same rules apply to everybody.
Just thinking, it makes me sad actually to hear that we are not seeing a lot of women of color. And it makes me sad because I see the same thing. We will present, but late as it relates to breast cancer. Oh, you'll come, but I tend to see, you've waited till it's, that mass has grown. And so it's no longer a primary prevention and now it's secondary, or it may be too late,
Right.
And so I'm glad that we're having this conversation, for you to know that there are people that look like us that you can speak to. But at the same time, we live in Canada. This is North America. You're not always going to see people that look like us, but you've got to show up, So how do you think, what do you think could be done to make more women show up? Such a generalized question, but I'm just curious, what do you think? Is it more of us in social media, more of us speaking out, more things like this? What?
I think it's actually a great question. I think part of this, I have to say, I think stems from it's not only, if we think, Christina and I are, practitioners that work in community, while we run these clinics, but I think a lot of it has to come from the top down, right? When we look at our national organizations, when we look at, certainly workplace organizations that center around, we really promote and want to make sure that menopause care is accessible to everybody. I think we really need to make sure that that whole aspect is truly inclusive, right? Whether it's having, women of color sitting in positions where they're able to help, drive the change and shape those changes, because I think we're also more likely to be the ones to say, hey, let's think about our Indigenous populations. Let's think about our Black populations. Let's think about our South Asian populations that we aren't thinking about. I'm not saying
Middle
that these,
Eastern,
absolutely,
all those
right?
More,
I'm not saying, again, it's not meant to be, tit for tat, but I do think we need to see a lot more diversity on a global and national aspect of things as well.
Now, speaking about, let's pivot a little bit and still somewhat in that same realm. I would love to hear your thoughts on menopause and mental health. There's so much talk about that, menopause, right? But it seems to be that the focus is more so on the physical symptoms, right? But of course, there's the mental health component, which doesn't get as much attention. I'd love to know your thoughts on that. What are you seeing in your practice? What are you seeing?
Right. Yeah. No, I agree with you. So when women do present, they don't obviously come and say, I've got menopausal symptoms going on, please help me. Generally, when they're presenting with mental health symptoms, it's tend to be, I'm depressed, I can't focus, I'm tired all the time, I can't sleep, I've got anxiety, I've got panic attacks. So these are like all these symptoms that come together. And some women will say, I've never ever struggled with depression. I never in my life. Or someone will say, I don't feel like I'm myself anymore. there's something not right. I really can't pinpoint. Or sometimes they will say, my partner had said, go talk to your doctor because it's not yourself. So those are the ways that they sometimes present. So I think, again, listening to their story. Is it mental health during menopause, or is there something going on in their lives that's kind of aggravating all these symptoms?
Are women coming in and saying, I'm depressed? Like that word depression, what does it look like to them in this phase? Are
Right.
they, because that word depression is used. I'm depressed. Well, what does that mean? Are you
Mhm.
sad? Are you crying? Or what is it? What are you seeing? If we could be a little bit more specific.
Usually they don't come saying I'm depressed.
Okay.
They could just present saying I'm tired all the time. I got pain all over. I have no motivation. That's another classical symptoms. I'm not enjoying the things I normally enjoy. So again, is how long is it going on for? Is it going on for 2 weeks, or is it persisting for several weeks to months? And so we kind of make a diagnosis whether it's menopause related, where the symptoms are quite short-lived and it's cyclical. It can be associated, if they're still having a period, it could be related to their periods, or is it something that's persisting for several weeks? So if they do have several weeks of symptoms, then we would make a diagnosis of depression. Again, detailed questionnaires and more detailed, in-depth conversation with the patient.
Okay. Well, that's really interesting. Now, I know you're not seeing a lot of women of color in your practice, but are you sort of seeing, the ones that you do see, are they willing to talk about the mental health aspect of it? And if are they open to treatment as well?
If I were to think about sort of, I've been providing menopause care for almost a decade. And right, so if I think about sort of where the pendulum was, speaking specifically around mood symptoms, I do think a lot more women are open to having those conversations. But I think, as Christina said, a lot of them, it's surprising how many folks don't see the connection, right, around things like, oh, I'm just not interested in things. I'm tired. I'm sleeping a lot, or I'm not sleeping enough. It's often, the latter we find during the midlife transition. And I find once we sort of phrase it in the way, as Christina was alluding to earlier, like depression and mood disorders and exacerbation of that is such a common thing we see. I think there's this element of like, oh, it's not just in my head. This is something that is happening. And, there is also hope along those lines. So it's not uncommon women will prefer to lean into counseling in the beginning, but we know where the data actually lies, that a lot of women who do have these mood exacerbations, specifically around depression, there's some really good data that we can use hormone therapy, menopausal hormone therapy, to treat these women.
Rather than antidepressants, you mean?
Correct.
Okay.
So often as a first line option. But I will often caution women to say, it's not uncommon. We still have to go back to our bread and butter. Yeah. And I think that's where the disconnect is sometimes, right? Is there still this stigma around the use of antidepressants? And it's not uncommon. Practitioners will sometimes initiate, antidepressants instead of hormone therapy. Often by the time to get to our offices and our clinics, they may already be on that. And we may be adding menopausal hormone therapy to potentially augment. Again, not everyone is going to respond to hormones. I have women who will, we add them, and it's amazing how well it does for their mood. And for some women, it's just not enough. So we still have to go back to our bread and butter. And I think sometimes that's where the disconnect is, right? There's still this stigma. Women would rather often be, I'm on hormones, rather than, I'm on an antidepressant, if that makes sense.
I just want to make sure I understand correctly. Are you saying, when you say go back to the bread and butter, what do you mean by that bread and butter?
So bread and butter.
Are you referring to women wanting to be more so on hormones or more so on antidepressants? Or
So more on antidepressants. So how would we manage a major depressive disorder? How would we manage generalized anxiety disorders? We'll still be going back to our selective serotonin inhibitors, our traditional antidepressants, right, that many of our patients are familiar with. So it's not uncommon that we still will use these concurrently during the midlife transition together with hormones, or sometimes in isolation if women aren't responding to hormones for their mood.
And if I could say, choosing the right antidepressant during this stage in their life is important, because there's evidence to show when the estrogen's declining, the dopamine declines and the serotonin declines. So again, picking this, so many different types of antidepressants, so to be familiar and be able to pick the right one for what symptoms we are treating.
Okay, I was literally going to ask you, why do we get those depressive symptoms? Is it related to estrogen? Is it related to progesterone? But
Yeah.
you just answered that the estrogen is declining, and progesterone as well probably has something to do with the mood, maybe?
More dopamine.
More dopamine.
Yeah, these are chemicals in the brain.
What is brain fog?
So brain fog is a cognitive symptom that, again, women go through during this period. It can present with, I cannot remember anything, or to be able to focus, to be able to do stuff. Or people will come and say, oh, am I getting dementia? I'm really worried that I really am not focused. I really can't get my things done around the house. I'm really struggling. So I tend to treatment-wise, I try to go back to the bread and butter of, are you sleeping properly? Is there a mood element to it? What is really going on, to be able to support them through that process? The good news on brain fog is it's just a transition. So most women you'll see do get better over time.
That's good to know. And I'm glad you mentioned that. Now, are they getting better over time without therapy? Like their brain fog is going to get better anyway? Or do they need that hormone therapy or whatever? Okay.
Yeah. So again, it depends on what other symptoms they're going through. So if they got brain fog with hot flushes or night sweats, insomnia, then hormone therapy would be really beneficial. But if they just have the brain fog alone, usually supporting them through that process.
That's good to know. You don't always have to be on something to... Well, I think that's positive. Yeah.
You know, and I think just to add to that too, I think a lot of women often find it's the cognitive symptoms that impact function at work, right? So I think that's where we often will see women presenting that, you know, a lot of women will already find ways to adapt. Okay, I can make a list, I can set reminders, like, you know, my family knows, like, you know, blah, 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 like do X, Y, and Z to make sure mommy doesn't forget me at soccer, like some of these things, right? But at the same time, it's when it starts to impact their performance at work, because what's often happening on a hormonal perspective is that we know there are physiological changes happening in the brain in terms of memory and processing speed. And so that aspect can be really hard for a lot of women, especially if they're not responding to menopausal hormone therapy, is how do I make sure that I'm still performing at work? And that part can be really difficult, because I've seen women, like we're talking high-level executives who have lost their positions or who have had to resign prematurely because of these changes, right? So it's amazing how that whole cognitive aspect can be so varied, and the extent of that impact on someone's quality of life can also be quite profound depending on who you're speaking with.
Interesting. You have some experience in the UK. Do you see any differences between the UK and Canada in terms of the willingness of women to come in and speak to their mental health and symptoms?
I think UK and Canada are pretty similar in the way they practice. There's a lot of evidence-based practitioners. The difference in the UK is I think there's a lot more clinicians out there who are providing menopause care. There's menopause clinics in the secondary care hospitals, as well as family practice. So I would think maybe access is a little bit easier over there. But I haven't practiced in the UK for 2 decades now. So
access and more. I mean, if it was not too bad then, it's probably
the same now.
So, which is, I think the UK is a little bit different and good in some ways, but I mean, it's not a perfect world, right? Okay, let's move on to menopausal hormone therapy. Now, I want to talk about this because I was saying hormone replacement therapy, and you told me it's menopausal hormone therapy. Why did the name change?
So I think kind of just stepping back, the whole idea that we're replacing what women may have no longer have, or, you know, I still remind women, well, you know, we know the menopausal transition is a decline in ovarian reserve. It's not like estrogen levels in most women go from to completely zero. And so the goal of therapy, and I think the idea about changing it to menopausal hormone therapy, I think is also a little bit more inclusive. It's a bit more in line with what the goals as menopause providers, which is to address women's symptoms, right? So my goal is not to have you, if you do a bunch of blood work and replace what I think is missing, right? We're really not doing that. We want to hear your story and treat your symptoms and just, again, provide a form of treatment. And so I think the name is a bit more supportive of how we want to ensure women are accessing care.
Yeah, I love that. And so to the listeners, I think one of the key things that both of you have been stressing is history.
Yeah.
It's individualized, tailored therapy, essentially.
Exactly.
Now, this is a big part of menopause, right? Because there's a huge talk about hormones. But at the same time, I want to stress that this is not pushing, okay, everybody's got to be on hormone, right? And so to start with, before we even discuss menopausal hormonal therapy, what other options are there other than hormone therapy to treat these symptoms?
So there are multiple, especially now we've got fairly newer non-hormonal options. So there could be, we can start with antidepressants, again, related to their history, related to their story as to what their main complaints and symptoms are. So there are types of antidepressants. There could be medication that we can use to stop the hot flashes, which is not a hormone. There's a fairly new medication that's now available that is specifically a non-hormonal treatment to prevent hot flashes. So we can use that in patients who have contraindications to hormone therapy now.
Are you allowed to say what it is?
The trade name is called Vioza.
Oh, okay.
Fezolinetant.
I should say the fezolinetant.
Yeah, that's interesting. Just because it's kind of good for people to do their own research and bring it to their primary care physicians and say, hey, what's that? What's what? Interesting. Omolayo, what role does exercise and diet play in treating perimenopause, menopausal symptoms?
So there's actually been several studies, mostly smaller studies, that have specifically looked at, using exercise as an intervention, nutrition as an intervention. And I think globally, I'll still remind women, exercise and nutrition have an important role, kind of looking at the midlife transition holistically, but we don't rely on it, nor do we recommend it as options for treatment in terms of a lot of the classic symptoms we've spoken about today. So the flushes, the night sweats, the sleep disturbances, the cognitive changes, depression, mood that women have. We know that there's a significant role in ensuring women are moving their body for their bone health, for their emotional health, for their physical health. There's some smaller studies that report, certain communities may be less symptomatic in terms of hot flushes or night sweats if they have higher consumptions of things like soy. But again, we wouldn't necessarily recommend nutrition interventions to manage menopausal symptoms. The role there would be more for, again, comprehensive holistic care. We know that, it's important for women to be following a Mediterranean diet. There's benefits for cardiovascular health. There's really good data around prevention for coronary artery disease. We know that nutrition support in terms of managing weight gain or weight concerns, protein intake when it comes to the natural progression of muscle loss that women will see. So a lot of important roles in terms of kind of including it in that treatment aspect of the prescription you might receive from your provider. But I certainly wouldn't encourage women or providers to be recommending those as interventions to predominantly manage menopausal symptoms.
I love that. Okay, now let's talk about menopausal hormone therapy. What role does it play and who should consider it?
So menopausal hormone therapy is now, I think, commonly known is the gold standard for managing menopausal symptoms. And when I say menopausal symptoms, this certainly applies to women in the perimenopausal transition as well. And those that should consider therapy are those, who do have moderate to severe symptoms, is what guidelines will suggest, where their symptoms are having impact on their quality of life. When I was speaking earlier around, there's over 30 validated symptoms when it comes to the presentation of menopause. I think it's also really important for us to remind, patients that we have validated symptoms where we have really good data to support the use of menopausal hormone therapy. So we often will see women come to clinic and they might have skin and nail changes. They may present with things like ringing in their ears, vertigo, joint aches and pains. Many of these symptoms are actually and have not been well studied in large randomized control studies to say if someone presents with those symptoms, those are great indications to use menopausal hormone therapy. So those women who not only, and again, it's a subjective process, right? Most patients who end up in my office, certainly they know it's having an impact on their quality of life. It's not a measure of, how much of an impact this is having. But I will often remind our patients that where the data lies is around using menopausal hormone therapy, which traditionally will be a combination of things like estrogen, progesterone. We have certainly other options on the market, but we know that they often are really good for managing symptoms of hot flushes, night sweats, sleep disturbances, symptoms of GSM, so the vulvovaginal symptoms we were speaking to earlier, and mood symptoms specifically, especially depression. Some of our other symptoms, and I often will refer to them as auxiliary symptoms, right? My job is to hold space for those who have noticed, an increase in joint aches and pains, who have noticed vertigo, ringing, skin and hair changes, some of these other symptoms. And so my rule of thumb is often, if someone has some of those 5 indications, right? Health Canada approved indications for menopausal hormone therapy. I often will say, let's see if your joint aches and pains get better. Let's see if your brain fog is better, right? But the challenge becomes, and there's this idea out there that if women sometimes present with joint aches and pains in isolation during this transition, that menopausal hormone therapy is the standard of care, and we still do not have enough data to suggest that. Who should be using it? We know that the earlier you start, the better. So I say that in a way not to say if you're not having symptoms, we should be putting women on these medications. They are, again, therapeutic medications. We want to make sure we're prescribing them to the right patients. But we know that often when we initiate it within 10 years of the 10 years within the onset of menopause, and ideally under the age of 60. And I think that hard fact rule around 60 can be a bit of a moving target. We see a lot of really healthy, fit 60-year-olds, 61-year-olds, 62-year-olds who really have no comorbidities. I've confidently often feel comfortable initiating therapy in those patients, but certainly guidelines will often say, we should certainly proceed with more caution in women over 60. And a lot of that tends to just due to age-related risks associated with things like cardiac disease and increased risk for things like stroke.
Okay, I was literally going to ask what is the why 60? What's so magical about that number 60? But you answered it. So you mentioned 5 symptoms. Do you mind just going over them again, like the 5 major symptoms?
Yeah, so the 5 Health Canada approved indications are for hot flushes, night sweats, women who have sleep disturbances, GSM, so those are the symptoms of, the vaginal urinary symptoms we spoke to, and then those who are struggling with mood, specifically depression.
I just wanted a nice recap so people heard that. Okay. In talking about menopausal hormone therapy, we must mention what happened with the Women's Health Initiative, which has created so much fear regarding the use of hormones. So would you mind commenting about that and what it is, what happened, why there's so much to do about hormones now?
Right. So what I'll just maybe start from the beginning. So the WHI or Women's Health Initiative study, so this to date is still, one of the largest, if not the largest, randomized control study that actually specifically looked at the intervention of menopausal hormone therapy, randomizing patients into, those who had a uterus getting estrogen progesterone therapy, those who didn't have a uterus having just estrogen therapy, and they had a placebo group, right? So these women thought they were receiving menopausal hormone therapy, but actually were not. Right. It had about 160,000 women enrolled. They started the study in the mid-1990s, and the first set of results were actually published around 2001 to 2004. And I think when we think back, I think many of us now truly realize the results of that study. And just to summarize, so mainly the role and the intervention in the study was, let's give women menopausal hormone therapy and let's see what the impact is going to be on chronic disease prevention. So it if we think back globally, it really was not only a symptom management study. You know, we give women hormones, what happens with their symptoms, but more importantly, are we able to see an impact on cardiovascular disease risk? Are we able to see changes when it comes to colon cancer risk, for example? And so one of the biggest lessons we learned around this particular study, and one of the things that I think is important to note, is that this was women who were all postmenopausal. We did not have perimenopausal women enrolled in this study. The age sort of spread in women in this study was around 50 to 76, right? So we had quite a broad range that, you know, were being offered and being initiated menopausal therapy over a period of time when they presented with symptoms. So when we look specifically at the estrogen progesterone arm, so these were women who had a uterus, one of the things that we noted in that study was that these women actually over time started to note an increased incidence of things like breast cancer, okay? The other incidence that we saw started to increase slightly was coronary artery disease risk, so specifically heart attacks, strokes, and clots. So that was one of the biggest alarming features of this study that actually alerted investigators to put a halt on this study.
And that was in the estrogen and progesterone arm.
Correct.
Right.
Correct. One of the things we also saw specifically in that arm was that we actually saw a reduction in hip fracture, right? So a bit of a positive there. And we actually saw that there was noted a small reduction as well in colorectal cancer risk, incidence, I should say, in those women.
Right.
Okay. So in those women in the estrogen alone arm, so these are women who specifically receive conjugated equine estrogen, okay? And the progestin, I should mention, was medroxyprogesterone acetate. Again, I mentioned those specific medications because most menopausal practitioners, actually, we don't use a lot of those products as much, but these were the specific ones they used in the studies.
So the progesterone was synthetic.
Correct.
Right.
Correct. And so the estrogen alone arm, we noted that there was, again, actually, you know, a slight increase in coronary artery disease risk. That was actually a bit more neutral. I correct myself. It was a bit more neutral. What they saw in that particular arm was an increased risk of stroke and clots. And they actually noted a slight reduction in breast cancer risk in that particular arm. So versus the estrogen progesterone arm. And I think one of the things to take note of that and why this study was so significant is because it was the findings from this estrogen progesterone arm that ultimately really shaped the trajectory and the interpretation of the entire study. So this study went on for about 25 years, okay? And there were so many lessons and interpretations and analysis that were done. But in the early 2000s, because this study was stopped prematurely, a very large study, the messaging at the time was we're killing women, right? Mm-hmm. We're giving women strokes, we're giving women clots, we're putting women into risk for heart attacks. These became headlines. And it became, unfortunately, one of those things, I think, you know, you could argue the idea of media and messaging.
A very dramatic way, huge press.
For sure.
Yeah.
Absolutely. And that all it took over science and a bit of rational minds. Mm-hmm. And so, unfortunately, the sort of backlash from the Women's Health Initiative study in the early 2000s until you could argue the last several years has been, you know, and again, breast cancer risk was a big one that came out of that, was that hormones are bad, right? You put women on hormones, you're killing women, you're harming women. You know, a lot of providers who would have gone through medical training or, you know, like Christina alluded to, she was practicing around that time. Mm-hmm. Most folks were advised to peel back and women were actually being told to come off. Every once in a while, I'll meet a woman in her 70s and I'm like, how did you escape the Women's Initiative? Because like they were, for some reason, were able to stay on it. So I think ultimately the sequelae of that study has had a very negative impact on how we manage women's care around the midlife transition. Mm-hmm. But I think thankfully, because we've had so many sub-analysis of the Women's Health Initiative study, what we've learned about from that study, which is often now referred to as this timing hypothesis, is that what really, really are key findings from that study and what is important when we're starting menopausal hormone therapy is when we started and who we started is actually really more important.
When and who.
Correct.
Thank you for that explanation. I think I wanted you to talk about that because there's this fear about hormones. And it's sad because the way that this was done, I do remember there's all these women on hormones and all of a sudden, boom, done. People get taken off. There's this huge scare about breast cancer. And correct me if I'm wrong, I think that decreased incidence in the estrogen arm wasn't even reported. Right?
Correct.
It wasn't publicized, so they just spread this whole thing about
Correct.
estrogen and progesterone and scared everybody. And even the demographic of the age group of the women that they use, it wasn't even women that were necessarily the correct age group, right? It was
correct. Like
older
they
women.
were starting women in their mid-60s. Like you show up to the doctor's office, you were enrolled in the study, you're 68, you get hormones. You're 70, you get hormones. And I think, it's interesting you speak to breast cancer incidence because one of the things we were talking about earlier was the incidence of breast cancer has actually risen in the times when we have not been prescribing menopausal hormone therapy, right? Exactly. In Canada, it was previously 1 in 8. Now, I'll correct myself, it was 1 in 9. Now it is 1 in 8.
In Alberta, 1 in 7.
And even worse in Alberta. Okay, that's good to know, right? So, and this is over a period of time when we weren't using menopausal hormone therapy. So one of the best ways I often will phrase it to our patients, and I think we need to proceed with caution, right? We'll say, okay, the estrogen alone arm actually saw a reduction. I think it would be silly of me to extrapolate to tell women and say, you know what, menopausal hormone therapy we will reduce your risk for breast cancer if you're on estrogen alone. I don't think anyone really could ever stand here and say that. But what I will say when it comes to the incidence of breast cancer, especially when women are on the estrogen progestin therapy, which are the majority of patients we see, is I will counsel them and I will say, according to Women's Health Initiative study, again, we have to remember they use different estrogen, they use a different progesterone. A lot of the common estrogens and progesterones we use now are what I like to call bioequivalent. So they're similar to what our bodies produce. So we generally feel like they're better tolerated. They're often safer. But the idea is that when we actually look at the Women's Health Initiative study, we actually did not see an increased incidence in the first 5 years these women were on hormones versus those off hormones in the placebo group. And so generally we would start to see an increased incidence after 5 years of use. And it generally presents as an extra 1 in 1,000 cases. Okay, so after 5 years of use, women in the estrogen and progesterone arm, we would see an extra 1 in 1,000 cases of breast cancer.
So quite small.
Very small.
A small absolute risk.
Very small, especially knowing nationally in Canada, the incidence is 1 in 8.
Yeah.
So I think that's really important for us to take in when we meet women and when we're trying to reassure them, because I do think that fear, those headlines from the early 2000s still resonates with a lot of our patients or their moms, right? They're saying, hey, my doctor took me off of this. This was horrible. Why would you ever in your perimenopausal transition? That's bad, right?
Yeah.
We really need to reframe how we sort of speak about risk and interpretation of data.
Yeah. No, I completely agree. And did you find now, after the Women's Health Initiative study, I believe that there have been other studies that, like you said, have shown that hormone therapy is beneficial, right? And yet women still have this fear. Do you foresee a world where that's totally going to be a thing of the past?
I think so. It's starting to change because women are getting more and more educated on menopause and menopause hormone therapy, the safety, and the practitioners are getting more and more comfortable now to prescribe. So I have a feeling that things probably will change.
Fingers and toes
Yes.
crossed. And the generation is different. It's a newer generation where, where people are more open to talk about things.
And like Omolayo said, we now prescribe different, more like body identical hormones, which are better tolerated with less risks.
Well, we segued into that. So I'm going to ask you, what kinds of hormone therapies are there? Like we hear about bioidentical, compounded, synthetic. What's the difference?
So very confusing.
Yes. It's confusing. I say this quite frankly, I'm a physician. I mean, this is not my field, but I mean, it's confusing because, you go out there, there's very few people like you that are out there giving correct information, and then you go out and women are giving compounded and you've got to pay for it, so it's expensive, so this has got to be better, and you've got to store it in certain ways, and and then even doing some research, you hear about bioidentical hormones, and you used a term
bioequivalent.
Bioequivalent, exactly. And then there's
Yeah.
compounded. So help me out.
Right.
Help us out here. What's
So
happening?
in our practice, again, we go through patient's history, decide if hormone therapy is actually indicated. So we go with pharmaceutically made products that are evidence-based, researched. We know exactly what's in those hormones. So it'll be a pill, it'll be a patch. Estrogen can be given transdermally through the skin as a patch or a gel, or you can take as a pill. And we always have to provide progesterone. So the progesterone that we prescribe now is, again, microgenized progesterone, which means it's more of a similar molecule to what our body makes.
So is that considered bioidentical but not compounded? Is that
It's considered as more body identical.
body identical?
Yeah, so it's similar to what our body makes.
So are we moving away from that? Should I just forget about bioidentical?
Right. So
Just don't say bioidentical.
Yeah, you know what? So bioidentical, and you're right, it's super confusing, especially to our patients, right? So the word bioidentical is actually would be synonymous with our estradiol-based products and micronized progesterone. But that word, I find, has been really twisted in, when we see certain, there's various practitioners who may lean more onto the functional medicine side of things, right? So I think it's become this marketing tool for a way for us to have this idea for patients that, if you're having something that is being compounded, that is being made just for you, if
yes,
exactly,
I feel special,
exactly,
yes.
that this is clearly better than what comes through Health Canada approved products. And what a lot of us don't realize, especially as a former pharmacist, it is very hard to get drugs approved in Canada. We have incredibly strict guidelines and criteria compared to organizations, internationally, including the FDA. Like, it takes years and decades for drugs to hit Canada's shelves before, compared to other countries, right? So I think with that in mind, there became this sort of marketing kind of, this competition around, if I'm making this, it's being compounded, individualized for myself, that must make it bioidentical, meaning it is exactly similar to what my body produces. And that's actually a fallacy. So that is why I think a lot of us practitioners, I often will use the word, if someone has compounded menopausal hormone therapies, I prefer to use the word custom compounded, right? We don't lean on those as much. International guidelines don't suggest we do that because the safety is it's unsure, right? I could get something compounded for Iffy or Christina, and I could get something compounded for myself, but I can guarantee you the kinetics and absorption is going to be different, right? So I think this is where we want to lean towards some of the pharmaceutical grade products, because we can pull up kinetic data. We've tested their safety. We know how much dosing you're getting, right? Versus a lot of our custom compounded products. There are exceptions to that rule. Like, I'll often find, occasionally if someone doesn't tolerate some of our pharmaceutical grade vaginal products, we'll compound some estriol, I should say, so E3. But outside of that, I tend to really, just similar to Christina, would lean on a pharmaceutical grade product.
Also to say the bioidentical products also have the exact contraindications. So they're not safe as they...
Okay, so I'm going to ask something here. You mentioned it's very hard to get drugs approved in Canada, right? Why then are there compounded hormones at all? If these are so bad, you have somebody out there saying, you know what?
Right.
It's hard for me to see a primary care physician, so the naturopath's going to see me, so I'm going to pay for it. And guess what? They're making a compound that is special for me, and then I can go to a pharmacist and talk to them, and they're going to make it. What's so wrong?
Yeah, it's a great question, right? So, and I think without a doubt, as we spoke to, access to menopausal providers is very difficult in this country, right? I think, I see wait lists in my clinic, and I'm sure Christina could speak to that too. I'm all for practitioners, it doesn't matter, supporting patients. But I do think it's important for us to rely on and understand that, most societies do not endorse custom compounded products. We cannot always guarantee that it is going to be consistent in terms of what is being compounded, and that's the truth. There's going to be some natural variability, okay? Safety, you could argue, if you think about, again, we don't really have data. Like if I go to my corner compounding pharmacy and have them make something for me versus, going to Health Canada approved product, I think if you think about the root of compounding, just if you think about pharmaceuticals in general, compounding and the compounding of medications often comes when you don't have other available routes that are Health Canada approved available. So that's often the route of it, for example. So I could say, I want to prescribe an antibiotic to a child. It's not available in this particular route, or I have a child who can't swallow this particular tablet. Let's compound it so that it's easier for this individual to administer. It's an alternative route that we're providing. My argument and the challenge to those who say, well, why wouldn't this be an option? Like, why is it bad? Is why would we not lean towards a pharmaceutical grade product when we know the safety? I know the data. I can confidently tell you what I'm dosing you, what you're getting. Like it's available. So why do we need to go about and parade this persona that this may supersede pharmaceutical grade products? And I think that's where the challenge for us providers comes, and that's the marketing part, right? Is there's this idea that custom compounded products should be preferred and sought after compared to available products, and that is not true. And again, if you lean to a lot of international societies, including the Menopause Society, they have great statements that these are truly not to be considered first line for patients.
Yeah, and to be very clear, I'm completely on board with what's FDA and Health Canada approved. I'm just trying to think of the person that's listening out there. So, for example, in the breast world where I tend to live in, there's mammograms, which we know it's best for early detection. And then there's thermograms, right? Which we know it's not good. Now, I can tell you, I've seen the bad effects of thermograms. I've seen women that have had thermograms and it's been called okay when in fact it's not, or it's been called bad and they come and there's nothing there. Have you seen any deleterious effects from people using compounded hormones? Can you speak to that?
Yeah, so when it comes to the progesterone component especially, that should not be given on the skin. It should not be a topical cream or a gel. The reason is that the reason we give progesterone is to protect the uterus lining from becoming precancerous and down the road becoming cancerous. So when they do the compounded components, sometimes it's given as a cream. Without giving an oral progesterone. If that's the case, there is a risk of the women developing endometrial cancer down the road if they're just taking the estrogen without the oral progesterone. So that's interesting. That's very important.
What have you seen?
Yeah, I would say similar to that for sure. Like you often see mismatching in dosing. And I actually also think, in my experience, often when I do see custom compounded hormones, the dosing, often when you translate them, are actually a lot lower. Right? Significantly lower than you would see in pharmaceutical grade products sometimes, right? You can see folks, sometimes practitioners will really titrate doses, but when you look at some of those standard dosing, they're a lot lower than what you would see in a pharmaceutical grade product, which makes you wonder, could there be a placebo effect driving this, right? Or are they truly having, benefit? And don't get me wrong, there are women out there, I've seen some of them through my office, their lives have been changed with their custom compounded products. And so often the opportunity I have when I meet them is to say, you know what, I understand this is working for you. I'm happy to hear you're feeling better. But at the end of the day, we don't have as much safety data around this particular product you're using. I can't consistently comment on the kinetics of what you're using. And I do agree with Christina that it tends to be, especially those with a uterus, we tend to be a bit more concerned. Are you getting adequate endometrial protection? Right? I think that part is key.
Okay, Christina, what are the contraindications to menopause replacement therapy?
Right. So the contraindications are actually
to menopause hormone therapy. What are the contraindications to menopause hormone therapy? I combined the words.
The contraindications aren't that many.
Okay.
The common contraindications, the most important ones are, number one, if somebody had a personal history of breast cancer. not family history, but personal history. If there's a history of blood clots, either in the deep vein in the legs or a pulmonary embolism, blood clot in the lung, or if somebody had had heart disease, a stroke in the past, or active liver disease. Those are the main contraindications.
And Omolayo, how would you counsel somebody that, say, had a personal history of breast cancer and is having, a lot of vasomotor symptoms, and they come to you for possible hormone? Like, is that an option?
Yes. As Christina already alluded to, like when we look at our standard guidelines, breast cancer is certainly still on the list. There is a bit of a gray zone when you speak to certain practitioners. I've certainly had conversations with well-known, breast surgeons, and, they certainly encounter patients in this, who've had a history of breast cancer, who are significantly symptomatic. And I would say up until February of this year, we didn't have the best options for non-hormonal therapies, especially when we're dealing with women who predominantly present with flushes and night sweats, right? While we know menopausal hormone therapy is the gold standard, I personally know in my practice, a lot of standard guidelines still suggest that not be provided as the first line option for breast cancer patients, okay? Again, I think sometimes it is a risk versus benefit discussion with your patient. Someone who was diagnosed with breast cancer, has a lumpectomy, versus someone who also has a similar history but now has bilateral mastectomies, we'd probably treat a little differently, right? Even though we know that, even having bilateral mastectomies, for example, does not mean your ongoing risk is going to be zero.
And it doesn't mean you've taken out all the breast tissue anyway, right?
Correct. But in early, 2025, we now have medication, specifically fezolinetant, which was spoken to earlier, that is a new medication, the first and only Health Canada approved non-hormonal medication we have on the market that's meant to target flushes and night sweats. We have options for breast cancer patients who do not want to take that risk when it comes to the exposure with hormonal therapies. So while we're talking about systemic management of symptoms, when it comes to things like GSM symptoms, is the use of vaginal estrogen and options for breast cancer patients? Absolutely. Okay. We feel very confident. There was a massive study that was produced last year in Europe with over 40,000, breast cancer patients looking at the use of vaginal estrogen. We feel very confident, but I would still encourage that we employ and explore the use of non-hormonal therapies, and medications like fezolinetant, I think, is going to be a great option for breast cancer patients without jumping to things like menopausal hormone therapy as first line in them.
Okay, well, that's good. You covered that nicely. And again, I was wondering about the vaginal estrogen, which is systemic. So maybe you can use it and then maybe not. Who knows?
Well, vaginal estrogen acts locally, right? So there is no systemic exposure, which is why we feel very comfortable. We have so many different options on the market. Like even there's a specific vaginal product that's an ovule that actually comes in 2 doses, a 4 microgram dose and a 10 microgram dose. So often in breast cancer patients, we can go pretty low when it comes to the use of vaginal estrogen. So again, breast cancer patients who struggle with GSM symptoms, we don't really have an excuse anymore. We feel very comfortable using vaginal estrogen in those patients.
Because it's localized.
Exactly.
Yeah. Okay, awesome. I love that. Quick comment on testosterone and its role in menopausal symptoms. What are your thoughts?
Testosterone.
Yes.
Testosterone.
I have people saying, why can't I take testosterone?
I know.
What are your thoughts on that?
You know what? Again, I'll kind of speak to it briefly. There is so much out there around testosterone. I think, a lot of the information we know about testosterone is, again, I think recently being driven a little bit by commercialization of menopause. But I will speak to when it's indicated, because we know that sexual dysfunction is a very big concern for a lot of our patients, right? And as we spoke to earlier, it is multifactorial. Currently, testosterone is indicated truly for only one indication, and that is in postmenopausal women who have concerns relating to low libido and desire. So that is really at this time, again, an off-label indication, but the only indication we have approved for the use of testosterone therapy. While there is a lot more information out there, and there's, some of it I think is subjective, some of it are weaker studies showing, maybe testosterone should be offered for muscle building, energy, all these other things. We cannot confidently say, and we do not suggest testosterone be used for those specific concerns and management at this time. Can we use testosterone in the perimenopausal population? Again, it's a conversation with your provider. I know my practice, it's something I've employed. Again, we get women where we've really addressed everything and they still aren't feeling great. Again, that's an off-label indication, a really important conversation to have with your provider to see if you're a great candidate. But I think there's so much more we need to learn about the role and how we should be using testosterone within the menopausal transition.
Okay, we're going to shift a little bit, and I think this is important. Can we talk about more of a gynae symptoms now? Okay. There are some conditions that we see in racialized women, Black women, things such as fibroids, endometriosis, and I just want to get your thoughts on that. What are fibroids? Why do we see it a lot in especially Black women? How do we treat them? Like this is why does it happen?
So I think it's first, maybe I'll start off by defining what are fibroids. So fibroids are, often described as benign growths that often, grow in multiple different layers of the endometrium. So that's the uterus. So they can grow on the outside of the uterus. They can grow within a muscle lining of the uterus. They can grow kind of protruding in the inner part of the actual uterine cavity. Most women who present with fibroids may not even be symptomatic. So there are many women who will walk around and their fibroid will never, ever become an issue. But many women, especially women who present with a history of heavy menstrual bleeding, painful periods, will often have a diagnosis of fibroids. And one of the, in the gold standard for diagnosing and identifying a fibroid is actually having an ultrasound. That's definitely the most common modality you'll see here used in Canada. If you're in the States, often sometimes MRIs may be more accessible. But that's often, it's an objective diagnosis that's made on imaging. I often like to describe fibroids as like real estate. And what I mean by that is like location truly matters, right?
Yeah.
It's not about, we'll see women who, they're told they have these fibroids, that's why it's causing your bleeding. You look at the location, you're like, well, actually, it's just there.
Yeah.
That's not why you're bleeding, right? And I think it's really important, especially in the perimenopausal transition, that, we think about this in conjunction when we're managing patients. So when it comes to the management of fibroids, and maybe before I jump to management, I think one thing that's really important to highlight is that there are certainly ethnic and racial disparities when it comes to the presentation of fibroids. They're incredibly common in Black women. We're talking 80% of Black women will be diagnosed or have a fibroid, compared to, other populations, which can range from 60 to 70%, depending if you're looking at, populations of white and Caucasian women or Asian women, for example. But they're incredibly common in the Black population. And why do fibroids occur? I think a lot of that is still to be determined. There's likely some, genetic predisposition without a doubt. There's likely some immune-mediated factors. But I think at the end of the day, they're not preventable. So I think that's really important, especially when we think about some of our cultural groups and, the decision to avoid medical therapy versus natural options. There isn't anything most women can do to prevent the development of a fibroid. And I think one thing that's also really important to keep in mind is that, there is often a genetic predisposition. So, if you have a female relative, a mom, a sister who's had fibroids, especially amongst a lot of Black cultural households, nobody talks about some of these health things, but it's important to sometimes ask because you are likely going to be more likely to predisposed to fibroids. So in terms
on that thought, sorry to interrupt you.
No,
I mean, because
of
I come
course.
from a family of, we're 7 girls and 1 boy, and every single one of us.
Yeah,
fibroids.
there you go.
So
yeah, there you go.
to your point,
No,
and
it's
my
so
mom
true.
included. Yeah.
Yeah, exactly.
Anyway, so go ahead.
Yeah. So in terms of treatment, we have so many different options now. And so often I like to start off with like the medicine. So what are the medical management, oral medications, injections, things that patients can use? So, the broad category would be to use hormones. It's not uncommon that, again, depending on where your fibroid is located, we might use, something as, more simple or low-hanging fruit like a birth control pill. We might use pills that have estrogen and progesterones in them, maybe just progesterones. We might use medications that actually put your body sort of into menopause. So they actually, will clinically reduce and cause periods to stop, which can often help manage fibroids in some patients. We've got some pretty novel agents on the market that actually will also reduce the size of fibroids now, which can often help with the bleeding a lot of our patients will experience. Non-hormonal medications that we'll sometimes use, specifically tranexamic acid. Again, I often describe those medications more as like Band-Aid solutions. They don't address the underlying issue with the fibroid. So they often more just address the bleeding. And for some patients, exactly. And for some patients, that's their preference. They don't want anything hormonal, or they're not good candidates for hormones. And then the last would be looking at intervention. So specifically surgical interventions, and that may be a gynecologist, so a surgeon actually going in and removing a fibroid if it's intact. So, the ones that tend to do better, those are submucosal, located right within the muscle and uterine lining wall. And then the latter would be sometimes, the definitive treatment would be to have a complete and total hysterectomy.
I want to add another treatment option here as a radiologist is the uterine.
Yes, UAE. I knew you were going to say that. I missed that one.
Yes, of course. The uterine artery embolization.
Yeah,
because that's something a lot of people don't think
that's
about.
A good point.
We were just talking how fibroids have just been brought to the fore because of Venus Williams, and to think that all she was offered was a hysterectomy. There are options, including, so speak to your local radiologist, get referred to a radiologist. And I mean, obviously, I think the pattern we've been talking about here, it's so individualized. So you've really got to talk to your doctor and see if that's an option for you. But
absolutely.
Yeah.
Absolutely.
Awesome. And finally, like endometriosis, what is this? Do you see, what are the symptoms? Do you see it more in racialized women, Black women, Southeast Asian women? What are we seeing?
So endometriosis, I think many women have probably heard of what that is. And I think, unfortunately, compared to fibroids, I actually think most women go a lot longer prior to being diagnosed. The reasons for that, I think, can be certainly multifactorial. So just to define what endometriosis is, and I often find the simplest way is I'll tell women, so we have, again, the uterus, so the cells that actually line the uterus. And endometriosis is when those cells often will migrate outside of the uterus. So they don't want to just stay where the uterine lining is. They want to go ahead and visit your appendix and deposit there. They'll want to deposit on your fallopian tubes, your ovaries, your bowels. You can see endometrial cells really deposit anywhere. And so when we think about the, reproductive cycle and what's happening with menstruation and the fluctuation of hormones, imagine having these cells, depositing on your bowels or depositing on your ovaries. They create local inflammatory reactions and often presents with women presenting with very heavy periods, very painful periods. And the classic thing about endometriosis is I think when we listen to women, we can pick them up right early in their adolescence. These are often women who present right off the gate. They're your heavy menstrual bleeders. They're missing school. They're missing sport. They're missing activity. They end up in our ERs because they just, that.
Is it from pain?
It's from pain, right? They end up in these crises and they often get dismissed because there's this idea that, this is a monthly thing. Get on and live with it. And unfortunately, the sequelae of not diagnosing women early can be quite catastrophic. So aside from the painful periods and heavy periods, a lot of women will also describe things like painful penetration. So they can be your adolescent woman that doesn't feel comfortable putting a tampon in. It's just incredibly painful. They'll often have painful bowel movements. Endometriosis often involves a lot of other systems, I should say. So many women will present with underlying history of mood disorders, depression, anxiety, irritable bowel syndrome. Right.
It's interesting.
Yeah. So it's really quite a complex condition. And I think, when we look at racial and ethnic variability, we know that generally, 50% of racialized women, especially Black women, will not get diagnosed in a timely fashion. And I think, again, this is likely multifactorial. We think about access to healthcare, discrimination, systemic racism. But what I found interesting when reviewing the literature is that, we actually saw, there's one report that noted that Asian women were actually more likely to be diagnosed. So 60% more likely to be diagnosed compared to some of the other counterparts. I can't quite explain why that is, to be honest. I knew you'd ask me that question. But I think
I'll have to look for that
no, for
paper and
sure,
see.
for
I'm
sure.
curious as to why.
That is.
Yeah.
But I do think one thing we know that most endometriosis patients can take up to a decade to get diagnosed. And so the sequelae of that can often be women living with chronic pain, living with significant mental illness, physical illness, which can certainly impact their work and their ability to sort of perform on a day-to-day function in society.
Okay, so just in wrapping up here, Christina, what is one piece of advice that you would give to women navigating reproductive health in this confusing environment that we have? And I'll ask you the same question right after.
I would say seek out help. Start off with your primary care provider. Try and educate yourself. Look up resources. There are very good resources out there with where they can look up information and find out a little bit about what's really going on, and then seek out help, starting off by talking to your primary care provider.
Dr. Famuyide, what do you got to say?
There's so much information out there. I actually really empathize for patients because, sometimes I think if I were in your shoes, how do you digest all this information that comes at you from social, paper, various different outlooks? And I would echo around, certainly informing yourself. So I think one of the things I think is really important is just finding really trusted resources. I think we live in a world right now that, I hate to say it, that, some of our most trusted resources are not even physicians, right? So we need to think about where we're getting our information from. I think, it's important for us to have these conversations, right? I think we need to create this culture of normalizing periods, normalizing, these transitions and the contraception, menopause, perimenopause, right?
Yeah.
Many of us feel comfortable going to the doctor and chatting about our sore elbow.
Yeah.
You should be able to feel just as comfortable. And I think that's going to come with time. I think a lot of that is going to come with society's interpretation of the value we place on women's health. But I think one piece of advice I would just, encourage our patients to do is not only, make sure you have good places to find your information, but have these conversations with your friends. I think that, that in itself is half the battle to know what is normal and what may not be considered normal.
Now, both of you spoke about resources. So what kind of resources would you recommend it? Because to that effect, you also mentioned that there's a lot of information out there. There's so much medical misinformation. Whatever you're looking for that you want to agree with, you will find on the internet, right?
Correct.
So where can people go to find reliable information on this topic?
I like how you said that, the way, like what you want to agree with, because that is actually very accurate.
It's so true. If
That
you
is
want your
very
ears
accurate.
tickled, you will find
Yeah.
it. I find people, you're looking for something to make you feel good. You're going to go out there, you'll find it.
Yeah, no,
So,
that's true.
But there's got to be a place where people can go and find reliable information.
Yeah. So some of my top 3 or 4, especially around like menopausal care, is I tell women to, take a look at the MQ6. It's an online assessment tool that was actually developed by a Canadian family physician. It's a really nice option to take into your provider, right? Has 6 simple questions around periods, mood, sleep. If you tick off any of those boxes, you can open up the conversation around perimenopause. The Canadian Menopause Society also has some really great online information around, management, finding a menopause provider in your community. The Menopause Society as well, which is a North American-based society, but, a lot of our Canadian counterparts, we really do sort of, fall nicely in line and agree with a lot of the recommendations there. So those are often like my top 3 for evidence-based, not just one person's opinion. It's often multiple different individuals that have come up with these recommendations for patients to use.
And for myself, I will recommend a really good UK website called Rock My Menopause.
Oh, yeah. Rock My Menopause.
Yes.
I love that. I'm even going to go there.
Yes.
Write that down.
It's by family physicians in the UK who specialize in menopause care. They put together this really great website.
Oh, I love that. Thank you very much. That's really good. Okay. Where can we find you, Dr. Kanagaratnam?
At Spring Creek Medical Centre.
Where you're the medical director and the founder.
Yes.
Okay. So if you go on your website, which is
springcreekmedical.ca.
Okay. And is it possible to book online, or is it a referral service?
Usually referral based through their family doctor,
Okay.
or they could call the clinic in to inquire if they could come in as a self-referral.
Okay. As I mentioned, you're right here in Calgary. And Dr. Famuyide, where can we find you?
So you can find me on social. So we have a couple different sort of handles there. So one is at the clinic, which is at Layo Centre. So that's LayoCentre. Or I have my own sort of like Instagram account as well. So just at Dr. Famuyide MD. We also have a website, which is www.layocentre.com. And there's some really great information there that we often use as a tool for patients who are even looking for, not just how to find out services at our clinic, but also just some great online resources around navigating midlife care as well.
Okay. Well, I can't thank you enough, and I really do mean that. Thank you from the bottom of my heart for being here and giving of yourselves to talk about this super important topic. A lot of this is driven by passion, and love for the work that you do. And to me, where there's passion, that's the best. And you've given of your time, to educate the listeners. One thing I noticed, there's a lot of, it's individualized care, right? And the information is out there for people to take. This is not medical advice, but I always say knowledge is power. So for people to take it and to know, you take this information and go back to your primary care physicians and have that conversation, right? So I thank you so much for being here. I'd really appreciate both of you more than you would ever know.
Well, I just want to say thank you for having us. And again, congrats on season 2 of the podcast.
Thank you.
And, I certainly respect a lot of the work you've been doing and highlighting, not only menopause, but other women's health related topics in Canada. So kudos to you.
Thank you, Fee, for inviting me as well.
Oh, my pleasure.
Really appreciate it.
Thank you so much. And that's it. It's a wrap.
Awesome.
We did it.
We did it. Oh my gosh. It's your first podcast.
You made it so easy.
You did good. Oh, thank you.